try to dissecting what would be the optimal management for this disease. This is my index of my talk, but we have to know that, consider the peritoneal carcinomatosis is the worst scenario for our patient. Why? Because the survival is decreased in our patient, and up to 20% of the patient will develop the peritoneal carcinomatosis, and the peritoneal carcinomatosis causing a significant impact on the quality of life of our patient and reduce the likelihood of survival in our patient, of course, and was historically have considered a terminal condition. Also, this study was very impressive when you study the survival. Patient with peritoneal carcinomatosis is different than patient with liver or lung metastasis. You can see here that the survival is worse than a patient with other type of metastasis. Also, if you see that only the patient with isolated peritoneal metastasis, the survival is the same that patient with multiple sites of metastasis than non-peritoneal site. It is very impressive. Then we have to know when we have patient with peritoneal carcinomatosis, what is the correct management for this patient? Always we have several doubts in the NDT meeting about patient with peritoneal carcinomatosis. It is true that it has not been explored indeed, the patient with peritoneal carcinomatosis. If you see on this table, you can see the most important trial that define the treatment of the systemic chemo that is used on the metastatic disease. You can see only on this trial, on all these trials, you can see only 1.8 of the patient have peritoneal carcinomatosis. Then this is a population, it is very underrepresented on the several trials. Because colorectal peritoneal metastasis is not the same than the hematological metastasis. The spreading, the tumor cell spreading from the primary tumor into the abdominal cavity, and the free tumor cell becomes susceptible to a regular peritoneal transport from the liquid into the peritoneal cavity in a clockwise flow, and the tumor cell attached to the peritoneum, transmesothelial or translymphatic, and also the tumor cell invade the submesothelium through the integrin-mediated adhesion. That is the mechanism. It's totally different than hematological metastasis. And then the treatment could be different. Then I invite you to think about the peritoneal metastasis not as systemic disease, and think on the peritoneal metastasis as a local-regional disease. Why? Because it's totally different, the pathophysiology of the peritoneal metastasis, different than the hematological metastasis. We have different prognosis and also different classification into the DNA classification. Peritoneal carcinomatosis is most resistant to systemic treatment. And also the ctDNA could be undetectable when a peritoneal carcinomatosis is established. And also we have a very difficulties about the diagnosis, about the staging of the peritoneal disease through the CT scan on MRI. Then we are going to think of peritoneal metastasis as a local regional disease. And then, as a local regional disease, the best treatment for this patient could be the surgery. But what type of surgery? The surgery must be cytoreductive surgery. What means cytoreductive surgery? Cytoreductive surgery means that include peritonectomy procedure and multivisceral resection. This is a very complex surgery, and this is a very, very aggressive surgery with a major morbidity, and we have to consider them because we have to select the patient for this type of treatment. And also, the selection of the treatment is dependent on the tumor burden, with a PCI, this peritoneal cancer index, more than 20 could be contraindicated for this patient. We are going to decide if the patient survive or not survive, that the imperator says. You are going to decide if the patient is resectable or unresectable. As Professor Adam said before, we have to be an expert committee, expert surgeon that decide if the patient is resectable or not. This is very important. The resectability must be decided in a specialized MDT with very expertise surgeon in the MDT. If you don't have expertise surgeon in your MDT, please ask for a second opinion. It should be performed, this type of surgery, it should be performed in reference units by experienced surgeon, and the MDT decision is essential for that. It is known that the surgery in colorectal peritoneal metastasis improves survival. This is an old trial, but this is a very important trial. It compares patients with peritoneal metastasis treated by cytoreductive surgery and HIPEC and standard of care at this moment. At this moment, don't have the modern systemic chemo, but the survival increased from 12 months to 22 months after the surgery. This is the very famous PRODIS-7 trial. The PRODIS-7 trial was a negative trial in order to demonstrate the benefit of the HIPEC in a short course of oxaliplatin using during HIPEC. But this trial was very important on the management of the peritoneal carcinomatosis when you see that the cytoreductive surgery in the both groups achieved a very high overall survival, almost 41 months of survival on this patient. If you remember, the study I presented before by Franco, the overall survival with peritoneal metastasis was 16 months of survival. But the surgery has to be a very high-quality surgery because we have to get a complete cytoreduction of this surgery. It is essential for the survival. If we eliminate all the tumor from the abdominal cavity, the survival of the patient will improve. This is my proposal about the management when we have patients with peritoneal carcinomatosis, and the patient could be potentially resectable with a very good ECOG and no other metastasis site. After MDT evaluation, this is the most important, in a referent peritoneal carcinomatosis center, we can decide for these two arms, or perioperative systemic chemo or surgery upfront. After this initial treatment, the patient will be followed up, and the patient could have a peritoneal relapse only or associated to other disease. We can consider this patient as unresectable and go to another line of the systemic chemo based on, for example, ESMO guideline. But if the patient is potentially resectable, we come back to the beginning, or systemic chemo, or is oligometastatic disease, and it is easily resectable, could be to re-surgery for this patient. This could be planning of the management for this patient. What is the timing? Because I put two arms on the beginning for management our patient. What is the timing for surgery? Upfront, or we need the perioperative chemotherapy? This is a fantastic trial. It's a Cairo 6 trial. It has been presented in ASCO this year that compare the patient with treated by perioperative chemo versus upfront chemo. And there was not any difference on survival, on overall survival between the two options, two strategies. But we have, on the secondary endpoint, we have a benefit on the progression-free survival, but it is remained that it is not clear about the timing of surgery. Also, this study, this is a retrospective study that matched the population between upfront surgery, between neoadjuvant chemo, did not find a difference in survival with the use of neoadjuvant chemo. And then we come back to other scheme, other program. You can see that at the beginning, surgery or systemic chemo could be both a very good option for our patient. And I think that MDT decision could be the most important key. About HIPEC on the peritoneal carcinomatosis, HIPEC should be offered for our patient. It is very controversial. This is the trial that I presented before about the cytoreduction surgery. But you can see here that the use of cytoreductive surgery and HIPEC increased the survival of the patient. But what did this affect? Surgery or HIPEC, the addition of HIPEC? It is not clear. On my opinion, cytoreductive surgery could be the most important thing for this patient. But the use of HIPEC, the rationale is good. The HIPEC could eliminate the microscopic disease after cytoreductive surgery. It has been seen in several in vitro studies, several retrospective studies, but any treatment have to demonstrate benefit in patients, and not only the rationale in retrospective study or in vitro demonstration. And when we are talking in oncology, and we are in this forum, in this medical oncology forum, the benefits in oncology are very clear. It's survival or quality of life. HIPEC in ovarian and pseudomyxoma, for example, have demonstrated efficacy when it's applied for this type of tumor. But, have I presented before, in colorectal peritoneal metastasis, no survival benefit using HIPEC was demonstrated. But it's not totally negative, this trial, because this trial did not demonstrate the survival benefit with the use of HIPEC with short course of oxaliplatin. Okay, that is the message. It's not the HIPEC, it doesn't work. No, it's short course or oxaliplatin doesn't work. Okay, it's totally different. Then on this trial, well, there is some post-hoc analysis on this trial that some patients with a limited PCI, with PCI from 11 to 15, have some benefit on survival. But there are very, very few patients to do a very, very good conclusion about that. But what happened? After PRODIS-7, it was a negative study, a survey was made between the peritoneal carcinomatosis surgeon, and the most of them switched from oxaliplatin to mitomycin C. Why we are going to use mitomycin C? Well, mitomycin C have demonstrated a better result in vitro efficacy when it's administered in vitro, comparing with oxaliplatin high dose. Then the viability of tumor cell was less than the use of oxaliplatin. This is rational. This is important, this rational. And also, mitomycin C is used on the clinical practice around the world, but it's not demonstrated. It's not strongly demonstrated the efficacy, but it is used. Also, in the Chicago consensus, recommended the mitomycin C for the HIPEC and only oxaliplatin short course for the PCI score from 11 to 15. Well, mitomycin C, there are very few studies that demonstrate the efficacy of the mitomycin C. This is a randomized trial that demonstrates that the use of HIPEC in locally advanced colorectal cancer using mitomycin C during 60 minutes could have a benefit on the control of the local regional disease for this patient. Then the mitomycin C could be some effect on the prevention of the peritoneal carcinomatosis. Then we have to continue to study about the HIPEC. There are some ongoing trials. This is a GCOP mitomycin C trial that it tried to compare patients with resectable peritoneal carcinomatosis will be randomized from